Hello. Weird hair. Okay, I gotta apologize for being tardy. Mr. Midwife is gonna be sad to hear. Hey, he's already here waiting. I'm sorry. I don't have a note for mom. I'm just late. I'm late. I have a good reason though, because with the ongoing saga of my amateur hour ability to provide good audio, I have a new microphone, and I thought I had it figured out, and I did not. So hopefully this is going to work out. It's lit up blue, so we'll see on the back end. Hopefully y'all can hear me. Raise your hand if I need to just shout instead. I think it's a pretty good echo in here though, because it's a bathroom, so I think it should be good. So if you're just stumbling upon this, my name's Bree. I'm a nurse practitioner working at ICU. This is a weekly get ready with me where I, put on makeup and wax pros on all the things in life about NPs, professional stuff, clinical stuff. I'm critical care, so we tend to talk a lot about critical care stuff, but today is actually a professional topic. And what are we talking about? We're talking about work options for the acute care nurse practitioner. I think I entitled the blog Job Options. I chose not to use the phrase work setting because I think part of the reason there's confusion on this is because we use different terms and people mean different things by these terms. And so you will hear a lot of feedback from people either in person or in forums about, where you can and can't work. People have strong opinions about this. It's pretty crazy. But when you really get down and do the research and try and understand what these terms mean, it makes a lot more sense. So I do mentorship, so I will often have people that will come to me like in the process of looking at NP schools and trying to decide what certification they want. And they're using the wrong terms to describe what it is they're looking for, and that's why they're confused. So I think it comes from a place of first understanding what these things mean, and then it makes a little bit more sense about why the argument I make about the millions of different places you can work with your acute care seem to make more sense. Because a lot of times when I go on the forums, I'll answer questions for people like, you have your acute care, you can't work outside the hospital. That is not true. That is absolutely 100% not true. But a lot of people don't believe me when I say that, particularly if they're not acute care. So that's the topic for today's video. And it might be kind of quick. I mean, this is not a super heavy subject, but as always, I am so thankful when everybody is here. Alex, hey, Alex, glad to see you here. Mr. Midwife is here. Sometimes Nurse Scott will jump in, although he's in the throes of FNP school, so who knows if he's crying in the corner somewhere and will show up or not. But by all means, let me know what you think. I love to hear opinions, input, clarification, questions. I welcome it all. This is a safe space. Sorry, just refreshing my little, I take all this content from the blog that I wrote, so I got to refresh my mind on what I wrote. Okay, so yeah, there's a caveat I put in the blog about why there's so much confusion about this, and the terminology is one piece of it, but the other part of it is there's not a lot of federal standardization as far as our certification and what we can and can't do. There's this thing called the LACE consensus model that came out in 2008, and that is how they kind of further delineated FNPs from acute cares and decided what work setting we would best be appropriate for, and it was based upon your education and training. So you'll hear a lot of people say acute cares are for the hospital, FNPs are for the clinic. And I only talk about these two because these are the two most popular. Well, I don't know that acute care is the most popular. In my role, it's the most popular, but it's really only about 10% of NPs are acute care. The vast majority of them are FNPs. So there gets to be a lot of confusion about who can work where and what. What is true in Georgia will not be true in South Georgia. And what is true in South Georgia will not be true in Massachusetts or California. Because, and I can tell you this with complete certainty, because I've looked at a lot of the board of nursing websites. I've read them, they're super gray, very open to interpretation. So when you get to these rural places like South Dakota, particularly if it's a critical access hospital in South Dakota, they are absolutely employing FNPs in the ICU. Absolutely they are. So these people go on the forums and say you can't work in the hospital if you don't have your acute care. That's not really true. Should it be the case? Possibly. Yeah, there's a definite good argument for that. Same reason why I as acute care should not be working in primary care. I don't have that training. So the arguments are valid. The problem is just that there's not real strong federal standardization, regulation, or monitoring of this stuff. So you will see different things in different places. It's really confusing. Alex says, we hear you, thank gosh. Hopefully this new audio is just going to be stellar and put me up to that. Like, I would be happy just graduating out of the amateur hour video making. It's been like 3 years I've been doing videos and I still stuck with the audio, which is fascinating because I am married to a man who works for Bose Audio. I don't know. He's not into this kind of thing. So anywho, definitely going to be using your services soon, applying to an adult GRWM program this August. Yay! Awesome. I don't know what part of the country you're in. Hopefully you are not having any trouble finding good schools. DNP programs are no joke. I actually just got a DM from someone late last night about DNP versus MSN, and she was trying to weigh the options of what she should do. And that's a subject I haven't really talked a lot about. I made a TikTok on it one time and it was super controversial. And because I'm not DNP, I feel like I have a hard time speaking without bias. But it may be something I have to address. So DNP programs are hard and long. So kudos to you, my friend. And I would love to meet you in person anytime. Scott is seeing patients as we speak. Oh, that's awesome. I love your little emojis. Oh, hopefully he is rocking it. I'm sure that he is. Can't wait to hear how that is going. God, I remember my first clinicals. I wanted to crap my pants. I was scared to death. I literally put on the white coat and just pretended. It felt like a big fakery fest. It sucks. Kiriki, hi. I love having a chick around. You are a girl, right? I'm looking at your picture. Yes. I have very few girls who speak up in these. So obviously I love everybody coming on, but I just always think it's interesting that it's sort of a get ready with me. It's mostly dudes. Currently completing my hospital medicine rotation. I'm in the adult GRWM acute care program. Awesome. Are you doing mostly days or nights? I find that most NPs who are working in a hospital setting are doing nights. And the way that, at least in my experience, the way that they utilize NPs in the nights and days in the hospital's role is kind of real different. So interesting to hear how your experience is going. I live in Pennsylvania and there are FNPs that practice in the crowd. Thank you. Yeah. I mean, it's just, here's the thing. And this is why I put that caveat in the blog post. People who speak from a place of 100% absolute surety about something, but haven't really stepped outside their region or seen a little bit more about what's going on geographically, it's just got a cringe factor to it. I mean, I don't know. People get so worked up about some of these NP hot topics. Like they get mean and aggressive. And I'm like, okay, y'all, just because you don't experience doesn't mean it is not true. So, anywho, I think eventually it'll get to a point where, yes, there will be federal regulation and the LACE consensus will be upheld and you'll have to be acute care to work in the hospital. And inversely, you should be primary care trained to work in primary care. So, I mean, that's really the way that it should be. It's just not yet because, believe it or not, even though you hear people say all the time, we're saturated, there are plenty of places that are struggling to find NPs to work. So you do what you got to do, right? Days in the hospital service. Okay, so you're probably doing a lot of rounding, and I'll bet you're doing a lot of dispositioning, sending people home, admitting people in and out. A lot of bureaucratic flow stuff that can get kind of. It's just, you got to be able to work fast for hospital services. I remember I did a 2-week stint with a hospitalist when I took my new job, just so that I could kind of meet people, network, and that kind of thing. And I was like, 20 patients? You have 20 patients to see today? Holy mackerel. Much respect, because that's a lot. Okay, let me take a second and start getting on some stuff here. Which one is the? Okay, yeah, we have winter makeup and we have summer makeup because Brianna is really just 2 shades of white or burnt red. But of the 2 shades of white, they're very different. So we have to have a different color for summer because I do, believe it or not, get a little bit of color. I progress from translucency to less translucent. I won't say tan because that never happens. This week has been super fun for me because I'm only working 2 days. There's something magical about being part-time. I was a part-time nurse for like the majority of my career before I went back to school. My husband travels for work. So when my kids were little, like it was just too much. So I really only worked like 2 days a week and sometimes less than that. And there's something magical about that one shift. I don't know what it is, but when you're only doing 2 shifts a week, you feel like the best of both worlds. You can live your best life at home. You can be a stay-at-home mom and you feel like it. You feel it when you're off, 5 days off, you feel that. There's something about that one extra day though that's exhausting. It takes you from a place of peace and happiness when you're at work and happiness when you're at home. Oh my, something's going wrong here. To then being like completely overworked. And it's a matter of 12 hours. I find that across the boards too. Like that's not just my like dramatic response. I hear that from a lot of people. And I think it's just because you're cramming like an entire work week into 3 days. And if you do them back to back, like it's too much. It's too much. We work too hard, y'all. Maybe we should just all move to Spain where we siesta in the middle of the day and enjoy life. And who cares about money? I don't think I can do that though. that's a little bit much. Kiraki's doing a lot of admissions rounding, discussions with family and case management. Yep, a lot of disposition planning, lots of it. Okay, so let's get started here. All right, the terms. Now, okay, so we're going to start with, well, let me tell you what they are first. So certification, which is different from degree, which is different from the population of patients that you're treating, which is different from the role in which you're working, which is further defined by the specialty that you work in, which is determined, which can be determined in multiple ways based on the work setting in which you are. So those are the terms I'm going to further define so that we can then go through, and then I'll really just list off. And this is completely just a list of every single acute care setting that I've seen and know about acute care people working in. And it'll make more sense once I define it. So what happened? What happened? Something, short circuit. Okay, certification. Okay, this is probably the easiest to understand. This is where you get certified from, whether you are certified by the AACN or the AANP. These are the credentials that are behind your degree on your title, on your resume. You are board certified by a certain certifying body, and this basically proves that you have the education, training, and skill set and board examination pass to say, yes, you can work in this setting. This is obtained by passing your board, by taking your test. It demonstrates to employers and the public that you have the necessary knowledge base to support your education and training. So we have to, as NPs, narrow our scope and therefore choose a certification that we want to obtain. And that is really how we get around going to medical school. So we don't have to learn about OB. Well, not extensively, there's a little touch of it, Mr. Midwife, just a little touch in my pharmacy section. That was about it. The rest of it was like, I don't even know about that. And that's why I spend the majority of my focus when I'm in school in a very, very fast program that is expedited without a residency, because I'm only focusing on this very, very narrow subset of people. And this is what makes it hard when a lot of people are going back to NP school, because we're used to being able to do whatever. So having to then narrow and choose, like, well, what if I want to do primary care? I don't like the idea of not having that option. But that's what you have to do. If you want to work in more settings, you have to get more certifications. It just is what it is. Degree, this is self-explanatory. Also, this is MSN versus DNP. Those are pretty much the only options for nurse practitioners. I'm not going to go into much detail about that because that's pretty much it. Yeah, I'm not going to segue and talk about the DNP thing. I'm just not going to do it. I'm not going to do it. I'm not going to do it because I did not come on here to make enemies today. Population. Okay, this is the focus of who you are treating. So think of this as your ideal client. So for acute care, okay, adult gero, acute care NP. So these are going to be older adolescents. For me, it's I think 16 and up. Adult geriatrics. For FNP, this is patients across the lifespan. These are pregnant people, so 2 people in one, all the way up to geriatrics, all of them and everybody in between. For a neonatal nurse practitioner, it is just neonates. So this is the population or the ideal client or your avatar, if you will. This is the type of people and the age of people that you want to treat. And some of it can be kind of like super subspecialized, like the NNP, but it can also be very broad, like psych mental health nurse practitioners, probably going to focus on people across the lifespan as well. So it varies based on the certification that you are wanting to get, that you are working on. Now, role, okay. This is where I think most people get confused, is in understanding what role it is you are serving. This is talking about the role of patient, the role that you are serving in regards to caring for people. It's the type of care you're delivering. It does not speak to the population, which is the age. It does not speak to the setting, which is the place, clinic, hospital, home health care, LTAC. It doesn't speak to that at all. It's only talking about the role in which you plan to treat these people. So if you are FNP and you are treating a population across the lifespan, the role in which you are treating them is in wellness, promotion of wellness, prevention of chronic or management of chronic illnesses, prevention of acute illnesses, but it's not going to be on the management of acute illnesses. Now, there's a little bit of gray here that makes it, again, more confusing, but in an FNP role, you can manage stable acute conditions. I know, don't kill me. It's so confusing. I didn't do this. Board of nursing did this, okay? I just helped to try and understand it, and I struggle with it myself as well. But this explains why FNPs can work and are preferred to work in urgent care type of settings. They can see people across the lifespan, and they can manage stable acute problems. So like the asthmatic who's having an asthma attack that needs nebs, they can manage that. The patient who has a fracture, they can manage that. So it's a little bit more acute than if you're working in a primary care clinic type of situation, but neither of them are truly life-threatening acute care. So does that make sense? I feel like I'm getting more gray rather than less clear here. Okay. All right. I kind of already said all that. And then, okay. All right. Another sub point on that, as far as the role goes, would be, let's talk about specialty clinics, because this is the gray area. This is the big gray area. Can an acute care work in a specialty clinic? Does an FNP have to work in a specialty clinic? And by specialty clinic, I mean a place that is not considered a patient's home, somewhere they're not going for like promotion of healthcare. It is going to be somewhere where they're going to manage acute problems with one specific organ system, or management of chronic diseases like diabetes. So an oncology clinic, orthopedics clinic, cardiology clinic, any specialty clinic, acute cares can work in this setting. It's where it gets confusing, I know. But most people hire FNPs or PAs to work in these roles, but acute care can work in these specialty clinics. Work setting, this is the last part. And this is how most people default to categorizing NP types. Inpatient versus outpatient. Those are the two biggies. Do you work in a hospital? Do you work for a hospital system? Or do you work in a clinic setting. If you look at statistics, you'll see the majority of NPs do fall into the stereotypical settings. However, there is a report that I'll put a link to in the blog that looks at, it's a survey looking at where NPs work. And it says that as many as 13% of FNPs practice in the inpatient setting. And inversely, 14% of acute care nurse practitioners practice in an outpatient setting. So there's a very small percentage of us who go kind of outside the norm. And some of that is region-specific stuff like we talked about in the beginning, and some of that is just work preference setting. So I believe this is where the lines get a little blurred, but I believe it's better to think about the possible population, which is the age and role in which you can treat people, rather than the setting. And that opens up a lot more possibilities to you. It makes it easier for you to understand whether or not you can apply for this job or not. And I'll tell you, the people who are hiring don't know. Most of them are not NPs. They probably aren't even physicians. They don't fully understand the nuances of the Georgia Board of Nursing and their definition of what our scope is and where we can and can't work. So it's sort of incumbent upon us to know where we can actually practice or not. So try and parcel it back down to, is this the population for my certification? And is this the role that have been trained to care for people in? So having said all that, here's the big list. Okay. Now, I'll tell you, the inspiration for this blog came from a client that I had who, I say this a lot. This is incredibly common, y'all. There are a lot of hospital nurses, and that's who I know, right? People who are in the hospital. But a big percentage of them who are going back to NP school are choosing to go FNP. And I always ask people why they're choosing to do that. Not to be oppositional, because I think that God knows we need way more people who are willing to go FNP, and particularly ones who want to work in primary care. But I just want to get to the root of why they're making the choice they are, because they need to fully understand that unless you move from where we're at to South Dakota or rural Georgia, you're probably not going to be working in a hospital setting as an FNP. You are going to be working outpatient somewhere. And is that what you really desire? Because you've been used to working probably shift work, only a couple days a week, but long days, dealing with more acute problems. And you're segueing to a completely different thing. You're segueing to probably a 9 to 5, a lot of patients per day, less interaction with coworkers, and just a different, more stable set of problems that sometimes can feel a little bit whiny when we're not used to patients like talking to us like we are in the ICU, to then go to a patient, a day full of a panel of patients who are coming in with complaints all day. Like, are you going to like that? And I just ask people because I want them to think through these things, not because I'm being oppositional at all. And I will tell you, in my anecdotal practice, what I see is the vast majority of them. In fact, I only know two. I only know two NPs in all the years that left ICU to do FNP, who stayed in FNP and who are working in FNP work settings and love it. The rest of them have all gone back for their postmasters. And some of them planned on doing it that way, and I think that's perfectly reasonable. Some of them did not. They just got out there and realized they weren't fulfilled in the way that they thought they would be, and then went back to do their post-cert. So my point in all this is, this client came to me and she was, same thing, hospital ICU nurse, was thinking she wanted to do actually she was really kind of dead set on doing FNP. I was like, okay, well, tell me why. And, once she explained it, if it doesn't involve, I desire a different relationship with patients. I want to, get to know people, and I want to develop long-term, over years, relationships with patients, you might not be super happy in clinic setting. And anyways, and so I said, well, why not do your acute care? Because she said, well, my reasoning is I'm tired of hospital work. I'm tired of working these long shifts. I want something more regular. I said, okay, why not do acute care and work for a specialty clinic? Then you have still the option of coming back to the hospital if you decide you don't like it. And her response was, well, I don't want to work in the ICU. And I said, okay, this is a common misconception that people have, is that if you are an acute care NP, you work in an ICU. And that's not where most of us work, because that's a very, very, very small subset of people who work in ICU. There are a million other places you can work, both in the hospital and out of the hospital, with your acute care. And so that's kind of where the inspiration for this list came from. Having said that, it does start with the ICU, because that is the common conception. And I think if you are going to do ICU, you have to be acute care, except for those few places. For the most part, you got to be acute care. So there are a million different types of ICUs, y'all. And I don't know, I mean, we all work in different kind of settings. Some small little hospitals, you may have one ICU and it's a, smorgasbord of different types of critical care patients, but there are a bunch of them. They're bigger organizations. You can have so many different like subspecialties in ICUs. Just so endless opportunities. So you can have a medical ICU, surgical ICU. And y'all, I've worked places where there are very specific surgical ICUs. I mean, trauma ICU is one. We all know about what a trauma ICU is, but there are special surgical ICUs, like Emory Midtown has an ENT surgical ICU. So, and that is that's a crazy, these are mostly for people who have ENT cancers or some type of anomaly that needed surgical care. And clearly this is a problem when you operate on this. They end up on a vent for a while, and they can get really sick. This is the dirtiest part of our body, right? So it's a very fascinating ICU. And I know there are many, many other special types of surgical ICUs. Cardiovascular, cardiac, like CCU, neurocritical care, pulmonary. There are pulmonary ICUs. There are transplant ICUs. There are hepatology. So Emory, Maine has I don't know what they call it anymore. It used to be called, it was on 5E, so we called it 5E. But it is a unit that is specifically designed for people who are in acute liver failure, and it is a nuts unit. They are on liver dialysis and CRRT, and they are maybe pre-transplant, post-transplant. So there can be very, very super subspecialized types of ICUs out there. It's all a matter of what floats your boat, what's interesting to you, what jobs are available. But that's classical, right? ICU for acute care. You can also work in the ER with your acute care. Most of the time, ERs are looking for FNPs because they want to employ APPs, aka mid-levels, in fast track type settings. They want you to do basically an urgent care in the ER. And acute cares can't do that. We aren't trained to treat across the lifespan. But if you want to work in an ICU and you desire to do the critical patients, the acute patients, so those traumas, the STEMIs, anybody coming in some places call these critical alerts. So they're coming in as very, very sick, already on pressors, already intubated. That's what you would need an acute care certification for. And some places, not my shop, but some places do employ NPs to help manage those patients. So if you want to work like that in the ER, you need your acute care. A lot of places. I have a client who was at, where was she? Cleveland Clinic? I think it was Cleveland Clinic. Super, super cool job there that she was applying for. That is they call it a house officer. And her entire role is basically to act as a first responder in the hospital. So she responds to all the rapid response calls. She responds to all the codes. She helps manage, stabilize them in the room, get them started and set up with ICU level care, because at this institution, it's so big, they may be holding on the floor for a long period of time before they can go to a unit. So her whole job is to be like the face of the ICU outside the walls of the ICU. Super, super cool program if anybody's interested. I think they have a fellowship, or was it a residency? I can't remember. That looks amazing. As far as the training you get, just looked, oh my gosh, so cool. Sim labs and time in the OR for intubations, and just a lot of resources for that. Very neat. Trauma team, you can work for a trauma, which is a little bit, so you have trauma ICU, which you could work just for the ICU team and manage patients in the ICU, or you could work for a trauma team where you go to other places of the hospital, like more stable traumas that are not ICU level, or you go to the OR and you assist with operations. Plenty of APPs do that, even NPs. So it's a little bit different based on where you work. Hey, Black Panther, I'm a high school student interested in being a nurse practitioner. What certification would you need to treat people of all ages, including kids and babies? That is a family nurse practitioner. There are a lot of different certifications you can achieve as an NP. These are just the most common ones, and FNP is the most versatile if you want to treat across the lifespan. There are some things like you can do adult gero primary care NP if you only want to treat adults and not kids, but not be in the acute care setting. There's a lot of like super niche ones that I went to a very big school and there were like 2 or 3 people in each of those programs. So those are for the people who know exactly what they do and don't want to do. For most people, I would say 75% of people that want to work outpatient, FNP is the route for you. It's the most versatile. Hi, Aggie Blessed. Thanks for joining. Okay, so other inpatient units teams. So this is kind of where we start segueing into the non-ICU type of stuff. So neurology, and you could be, like I said, neurocritical care. You could be doing interventional neurology. Some places use APPs for neurology teams that are doing like coils and clips that are going in and actively treating strokes, thrombotic strokes, going in for retrievals. They will assist from the start to the finish, from the time they get a call in the ER or on the floor and evaluating them for whether or not it is acute stroke, to coordinating, getting them into the lab, to managing them afterwards. Some general neurology APPs are doing just typical neurology consults, admits, mostly consults in the hospital for neurology is what I see. You're going to get a lot of calls on stupid stuff like encephalopathy because everybody in the hospital is confused, to, chronic stroke patients, to new stroke patients. You could be working in just a stroke floor, not necessarily stroke ICU, but could be just a stroke floor. You can also, some of these specialties, neurology would be one of them. What makes you super versatile as far as acute care goes is most of them will split their time between clinic and the hospital. And you can offer a lot more to a team that has a clinic by offering the option to round in the hospital. And again, I say this with a grain of salt because there are places in the US where you don't need your acute care, but we're talking about the majority of places, okay, which do require acute care to go into the hospital. So with that, you can see their patients in clinic and you can round on patients, once a week, or when somebody's out, you can fill in for someone. So the big takeaway after this whole video and the whole blog post is this: with the acute care, a lot of people will say you're very niche, you're very narrow, you don't have a lot of options, but you actually do have a ton. And not only that, you can command more salary. And I have a personal experience with this when I applied for a melanoma clinic position, and they were going to offer me 15% more money because I offered that option of being able to round should they need me to. So even if you think you've been working in a hospital, that's your experience, you're sick of it, you don't want to do it anymore, you can still go to work in a clinic as an acute care and possibly make more money. So keep that in mind. But most all of these I'm fixing to talk about, you can bounce back and forth, and many of them do. Many of them will rotate. They'll do like a week of clinic and then they'll do a week of hospital. Some of them are strictly one or the other based on their preferences, or scheduling needs of the team. Okay, let me pause for a minute and answer some questions. So Aggie says, do you need first assist to help in the OR as an NP? Yes. Yeah, you really do. So legally speaking, I don't know the answer to that, but in practice, what I see, almost all NPs that I know of that work in an OR need a first assist, but it's like super simple to get. There's a video on my YouTube channel if you're interested in that, where I think what the title of it is, I interviewed Adam Smith, and I think it says interview with Adam Smith, vascular surgery NP. He went from being a trauma ICU NP to being a vascular surgery NP, and he got his first assist, and he talks in detail about that process, about who he did it through, how long it took, what the process was like. It sounds pretty straightforward. Honestly, it sounds like a bunch of online stuff you have to do, and then whoever is training you in the OR that's where you're getting your hours of practice. So it's basically just a prolonged orientation phase, kind of from what I'm getting. It doesn't sound super complicated. But yes, I think most of them do require you do it. I think even if you've been an OR nurse, I think it's required because you're working in a different capacity, in a different way. So I'm going to say yes. Oh, and Ad said yes. Thank you for answering that. As an RN and NP, that's exactly true. One of my best friends is an RNFA. She makes a lot more money as an RN because she's an RNFA. Can you work part-time as a travel nurse and part-time as an FNP certified? Absolutely. There are a million people who are doing that right now. You absolutely can. Yeah, I don't have anything more complicated to add to that. Yep, you absolutely can. It's much easier if you are currently a nurse and still have an active license and have proof of time spent working as a travel nurse or actively treating patients as a nurse. Because what I found during COVID, I wanted to do some travel nursing work because nurses were getting paid more than NPs were, and nobody would hire me because it had been like more than 5 years since I'd been at the bedside, which I was like, okay, come on, I can pick it back up, but they wouldn't do it. So, but for me, it probably would be much harder, but for somebody who's still actively working and could show the experience that they have, it's, yeah, no problem. Lots and lots and lots of people doing that. And that kind of gives you a little bit of balance too. Okay, so more inpatient specialties, hospital medicine. So that's the second, probably most popular setting for NPs to work in. 1 second. I did not spend any time for hospital service, but I know a lot of people who that's how they started, and then they segued to ICU after a little while. And I think it's a great way to start. It's sort of the same, like, you know, when you're a brand new nurse and you spend time on med surg before you go to ICU. It's a great way to do it. It really is, because it kind of helps you to sort of get your feet wet and learn some of the basics. You know, it just... It allows you to learn workflow, like typical ways of writing notes, because as a hospitalist, as you know, you're going to be doing a lot of disposition notes, lots and lots and lots. So you get very, very good and efficient at writing notes, figuring out where your resources are, sorting through what it takes to get a patient well, to get them home, and dealing with some of the more like minor problems and complaints, so that when you progress to the bigger problems or complaints, you can kind of filter out what's big and what's not big. So it's a great way to do it. And most hospitals, NPs that I know of, work 7 on, 7 off. That's the way the hospital systems want us all to work, and I hate it, but many of them do. What color should we do? This is always a difficult decision. I think I'll go here. And then pre-surgical sites. This is one that I think a lot of people don't know about, because unless you've worked somewhere like this as a nurse, you're not really aware that it's an option as an NP. And I think it's a great place to look for jobs as an NP, because you can provide a lot of value, free up a lot of time for physicians. And so it's a big draw. A lot of places want to hire mid-levels to work in these kind of settings. So you're basically working patients up before surgery, like the day or week beforehand, to make sure that they have all the necessary workup, labs, EKGs, whatnot, to make sure that it's going to be safe for them to get surgery. The other side of that is going to be like your post-op areas. Okay, let me see. Do you take call as acute care NP? Depends on who you're working for. So in an ICU, I do not. I think most ICU settings you don't, because ICU is a little bit different, because you got to have somebody in-house at all times. So it's 12 on, 12 off, for the most part. Other places you probably will. Other teams you may, particularly if you're on a surgical team or an interventional team of any sort, because it's hit or miss as to how many patients you have that day. So some of them do, some of them don't. And it is a big piece of your negotiating power if you have to take call. The other thing with call is not necessarily so much as I need you to be on call in order to come in, but I need you to be on call to answer phone calls. So I know a lot of cardiology APPs who are required to take call. Particularly the services that don't have someone in-house at night, cardiology being one of them. I'm trying to think, like, these are those like sort of like semi more acute specialties where you would need to get in touch with someone overnight, at least as far as in the hospital goes. Like something like infectious disease, you're not really going to need to call them in the middle of the night, right? Neurology, you probably will. Nephrology, you probably will. So those services are probably going to have some call, but they may not have the volume needed to keep someone in-house at night. Now, from an outpatient perspective, yes, a lot of people take call, and it's mostly in regards to who's answering the phones, who's responding to all those in-basket, like urgent in-basket requests. And that's going to be very dependent upon the clinic setting and what you do. If it's if you have like an after-hours clinic or something like that, you may have to. But for the most part, those places don't, because these are not acute problems. They can wait 12 hours until the morning. But if you go to work somewhere where you have to take call, absolutely negotiate the crap out of that. Don't take that whatever measly $3 an hour or whatever they're going to offer you for it, because it ain't going to be worth it. Let me just tell you, because some of these places you take call for, you are awake all night long. It is not just a simple little, I'll sleep tonight and make a little bit extra money. A lot of time you're up all night answering the phone. Okay, Black Panther says, does it matter the prestige of the school or schools you get your certifications or degrees from when finding jobs? Yep, for your first job. And this is if you don't have something already lined up or decent options for networking based on where you live. So look at the region where you live. If you hear people talking about it being saturated, if there's not a lot of jobs posted online, if you talk to other NPs in the area and it sounds like it is a tight market and you don't have really a lot of places you can network, then yes, the reputation of the school that you go to is almost 100% of everything. Because I sit on a board, I hire a lot of people. I work in a job where we are constantly hiring new people, whether it's physicians or APPs. And I am part of the group that interviews people when they come in. And 9 times out of 10, we are hiring people that are referred to us or that we already know from clinicals. But when we are looking at hiring someone that we don't know, and we just have, all these resumes that are submitted to us, there can be a lot. There can be a whole lot. And the name of the school is the first thing that we look at. So there are certain schools that just won't even be considered. I'm sorry, like you can be the best NP coming out of a subpar school there is. But if I don't know you and all I have to go on is the reputation of your school, and there are 9 other people that I can interview that came from stellar schools, why would I even give you the time of day, right? So yes, reputation matters a lot more than people give it credit for. When I was in school myself, I did a lot of rotations, and most all of them told me that they threw away resumes with certain schools on them. So it absolutely does exist. Is it biased? Yes. But they have the power. They have the power. They have the one job that 10 people are applying for. So they can do it. Alex said, great video on the topic. Yeah. How to choose an NP school. Yep. Kirky says, I also like a video about how to sell yourself to a pension employer. Oh, thank you. That was one of my favorites too, because I don't know, there're just a few little things that like I really wish that I had known. I didn't really have a problem finding a job, but I wish that I had known these things going into my job acquisition process. Could have made things a lot easier. And one of them is that calling card, which is my favorite thing to tell people to do, because it really, really does help. So yeah, if you're looking for a job, go check that one out. So a person who graduated from Duke has more advantage than a person who graduated from a public state university. I mean, that's sort of possibly, yes. But what I'm really talking about when it comes to schools is like, did you go to a state school or even an Ivy League school, or did you go to a diploma mill school? And I don't usually list names publicly because I feel like it's in poor taste. And I don't want to be that kind of person who may or may not say, you went to a crappy school. That's just not very nice or respectful. And there are plenty of great NPs who come out of crappy schools, but you probably know what I'm talking about, the diploma mills. If you've heard people talk about it in regards to it being a diploma mill, That's what I'm talking about. I didn't know you guys look into schools. That's interesting. Yep, absolutely we do. It's incredibly competitive. So, and that's why it's incredibly competitive. Let me get a little bit of more stuff on here. Yep, we look at schools. Really and truly, the best way to hire someone is like a student that we've had in clinical rotations. We've hired people that are 9 months out of graduation because they were so good. Your clinical rotation is a working interview. Make no mistake, it is a working interview. Even sometimes if they don't have a position open, if you come through and they like you and you impress them, they will make one for you, or they will keep your information on hand for when they do have something open up. So be on your A game for clinicals. It would not be a get ready with me if I didn't drop something, right, guys? Every single time. I didn't poke my eye today, though, Mr. Midwife. Are you proud of me? No, I poked. Well, I haven't gotten to that stage yet, though. The hubris. Should not say that. Okay, so continuing on with our list. Interventional teams. I think a lot of people don't know about this. Interventional radiology, interventional pulmonology, interventional cardiology, interventional neurology. So these are teams that are mostly APP led. Sometimes it is just an APP and possibly a specialty physician, whether it's a radiologist or a pulmonologist who is sort of your collaborating. But many of these are run independently. At Emory, Maine, there was a girl, I think there were 2 of them who did interventional pulmonology, and they went around all day doing chest tubes and thoras and bronchs. IR teams are very, very popular at almost every hospital you go to. They do a lot of stuff. I actually interviewed my friend Jim. I have a video on that one too. And this sounds like a big plug for all my videos, but he is a new grad NP who started last year, beginning of this year in IR. And I loved hearing about all the different types of procedures he does, because I know about the typical stuff like PICC lines and drains and biopsies, but everything, bone marrow biopsies, thyroid biopsies. They put in drains into every part of the body. They do chest tubes. They do everything. So if you are a person who likes to work with your hands and you like to do versus sitting and charting, which is what most NPs are doing, this is a very good role for you. And the days go by fast. It feels very productive. You get a lot of variety. So it's a cool job if you're into that kind of thing. Observation units, lots and lots of observation units employ NPs. Cardiac obs, medical obs, ER overflow, all of those will employ NPs and would prefer to employ NPs because we're cheaper. And it's fairly standardized care. This is good for somebody who maybe is a little bit intimidated by being an NP in the hospital, because you are very well supported. You have a lot of the same type of patients. It's the same stuff over and over and over and over again. And it's just a little bit less intimidating to start with. So yeah, lots and lots of that. But it's also going to be kind of like the hospitalist role who works during the day. It's going to be a lot of like turnover, progress note, discharge note, progress note, discharge note, a lot of this kind of stuff. And to me, that gets really cumbersome, but it's also a much easier note to write. So there's that. GI, gastroenterology. I am getting ready. We don't have a date yet set. I'm getting ready to interview a PA, actually, who works for a gastroenterology team, who is a bad A. I mean, to a T. She is the coolest, smartest, most just fascinating mid-level providers who works for a team. Anyways, I say all that to say that she works almost independently. I pretty much never see her doctors. When we consult GI, I only see her. And that is because when you work for a team, one of these interventional teams or surgical teams, your role is to manage the patients so that that physician can be doing procedures or surgeries, because that's what makes money and that's what they prefer to be doing. So you're managing the patients, you're taking in the new consults, working them up, making a plan for them, talking to the physician, getting them scheduled for a scope, dealing with, this is be a service that would take call, a patient that is acutely bleeding in the ER and needs a scope right now, helping coordinate that, helping determine how emergent it is. And GI is one of those, I think, fields that people think are fairly straightforward and simple, and it's not. You deal with a wide range of problems from here to here. So very, very cool specialty if you're interested in that. Oh, you're absolutely welcome. You're absolutely welcome for answering. Do you have to work weekends as acute care NP? I do, yeah. Some places don't. Some places will hire Baylor people or people who are weekends only, so you won't have to. But for them, well, you said it was acute care, not ICU. Okay, I'm answering as ICU. So acute care, no, plenty of them don't. Most of these teams actually only work Monday through Friday. It all shuts down on the weekend. So yeah, you don't. You can work in-house and not work weekends, and you can work clinic and not work weekends. And for the most part, if you're working clinic, you're not going to be working weekends. That's the draw really of clinic, right? Is a regular schedule, 9 to 5, kind of home with your kids in the afternoon, more predictable, no holidays, no weekends. That's the draw to that kind of work. It comes with its downsides, but that's a real positive. So yep, acute care, you don't have to work on the weekend or nights. You don't ever have to do nights. Go for a service who doesn't provide night coverage. Lots of options. That's my whole point. There's a lot more options than people think. Hematology, oncology. Of course, I have a soft spot for this. Y'all probably know this. You don't need me to tell you that over and over again. But hem-onc is a fun specialty. Orthopedics, rheumatology, urology, endocrinology, nephrology, pulmonology. All these like specialties, right? And you can do them. Almost all of these have both inpatient and outpatient settings that you can work in, and or both. So that's kind of cool. Keeps it fresh for you. And then I'll talk about cardiology, and I had to pause and add on some details on cardiology because my gosh, cardiology is like the biggest team of NPs there is anywhere. My first experience with meeting a nurse practitioner who worked in a hospital was a cardiology NP. I didn't know for the longest time you could work in a hospital as an NP. The first one I met was in cardiology, like general cardiology. So they hire a lot of them. And the reason is, I mean, it's such a prevalent problem in the US and there just aren't enough cardiologists. So, and there's so many different, okay, here we go. Here we go, Mr. Midwife. So we can, this is be an example of a perfect way to like subspecialize. So you have general cardiology, you have interventional cardiology, you have a CCU, some of these CCU NPs, I mean, you're working in very, very sick, like advanced heart failure, transplant centers, ECMO teams, working with very, very sick patients, VADs, cardiogenic shock on Impellas or balloon pumps. So that would be an example of like your ICU NP. You could be working for the interventional side of things and working in the cath lab. You could be working for a structural heart team where you set up caths and MRIs and all this for people. You could be working in a stress lab. You could be working on a telemetry floor. You could be working on a step down because they have to have their own APP because they do so much of the in and out thing. EP, you could be working for an EP team where you go around and evaluate pacemakers and take them out when you need to and put them in when you need to. You're going to probably take a lot of call on people who have SVT or bradycardia, putting in TVP wires. What else? Heart failure for sure. And heart failure can be anywhere from, like I talked about, the unit to just regular heart failure. You could work in a transplant unit. You could work with a cardiothoracic team. You could work with a cardiac surgical team. And almost all of these have their clinic counterparts. So even the cardiothoracic surgery team, they have clinic, right? Because actually most people who need cardiac surgery, they're elective. They got to start somewhere. So they'll see patients in clinic. And a lot of these teams have they'll have their core staff who are working just in clinic, and their core staff who are just in hospital. And then they'll have some that'll kind of rotate. It depends on where you go and like the culture, how they've set up workflow, and kind of, hopefully they give you some leeway for what it is that you want to do. I feel like a great balance is doing both. But a lot of people don't. A lot of people just want the regularity of whatever it is they're doing. Palliative. So palliative is interesting. Everybody knows what palliative care is. You can certainly work in the hospital as palliative care. Some palliative care teams have I think they're kind of unofficial subspecialties where like some palliative care team members are just doing the ICU ones. Some of them are doing the floor ones. Some of them are doing just the cancer ones. And I think they tend to base that on what your preference is. But did you know that you can also work in a palliative care clinic? Yeah, there are a lot of palliative care clinics around, and it's a wonderful service. It's a step, it's not hospice. It's different than hospice, but you will be managing people with acute symptoms, and you'll be managing people that, have terminal diagnoses and helping them navigate the process as they go through it. They kind of border a little bit on pain management, but it's mostly about symptom management of death. So that's palliative, infectious diseases, inpatient rehab. I have a friend who works in inpatient rehab. He loves it. Outpatient rehab, long-term acute care facilities. So LTACs employ a lot of APPs, and actually it's a little bit of a gateway. Like if you think you wanted to go into critical care or ICU, spend some time in an LTAC. It'll be easier to find a job. They'll be a slightly less acute. And you'll get used to trachs and vents and pegs and some of the inpatient drugs that we use. Some of them even do surgery in their LTAC sites. So yeah, great place to start. And there's usually jobs for those. Surgical teams of varied focus. So bariatric, general, trauma, orthopedics, vascular, cardiovascular, et cetera, et cetera, et cetera. There's lots and lots of surgical teams. Dermatology. Having said that, I don't know any dermatology people who are coming in the hospital, but there are plenty who work in outpatient setting, and you can do that as an acute care. And that was the end of my list. And that is by no means comprehensive. That is just what I could think of when I really racked my brain. Basically, if it's in that role and population, it doesn't matter the setting that you're working in. The role in the population is what matters. So the takeaway is that, don't let the dialogue out there about what you can and can't do as an acute care dictate whether or not you go acute care. Choose to do acute care if you desire that kind of relationship with that population and that role of patients. And then you can back into whether or not you want to do 12-hour shifts or 5 days a week or take call or not take call. And that will be based on the type of work setting and the specialty that you go into. But all of those are options for you. They absolutely are. Don't let people on these Facebook forums tell you otherwise. No, you don't just have to work in the ICU with your acute care. Okay. Oh gosh, this is funny. Okay, let me back up a little bit. Anything with ology in it? Yes, that's the takeaway. Ology, because family practice, internal medicine doesn't have ology in it. Yeah, you're right. That's funny, except you can't do neonatology. What certification would you need to work in rheumatology? FNP or acute care, you can do whatever. It's kind of like endocrine. It's a specialty, possibly even a subspecialty. Rheumatology is a very fascinating field that not a lot of people want to go into. That is some complex stuff, okay? I think rheumatology more so than endocrinology for sure. I mean, the problems you encounter in rheumatology are so vast, and there are so many autoimmune disorders out there. We don't have all the time coverage for rheumatology in-house, but we do have them available sometimes. I'm not sure I fully understand their schedule, but they're always available by phone, and that intimidates the crap out of me. Every time I have to call a rheumatology person, I'm like, okay, put on your smart cap here, Brianna. Let's do a little up to date before we go over there and figure out what this autoimmune thing is supposed to have and oh my gosh. And then they quiz you and you're like, I don't know. Your dumb shows up. So rheumatology is for the smart people. It's a very academic setting. But I think it's cool. I think it's a really cool field. The mascara makes me nervous. I know. I never got nervous until Mr. Midwife pointed it out. And then after that, I manifested it and poked myself in the eye not last week before last. So now I'm nervous. I don't know. Acute care nurse practitioner can work in clinics. Yep, absolutely. And that's because that's the dialogue out there. That's what people will tell you. It's a common misconception. A lot of people think this. Fair amount of people pay me money for me just to tell them that. I'm like, okay. It's just because we don't do a good job in our profession. Our board of nursing does a terrible job defining what we can and cannot do and helping us to determine our scope too. I have some clear bias against the board of nursing, but anyways, trust me, you can work pretty much wherever you want to work as long as it's the right population. You can't do mommies or babies or children, and you cannot do primary care. So if the clinic you're going to work for is considered the medical home of a patient, if you're writing refills over and over again for something that's not organ specific, that's like chronic disease, whole body, you can't do that. You can't, if anything that's going to require you to know guidelines as far as vaccine schedules for kids or how often you're supposed to get a mammogram, the recommendations on, maybe not recommendation colonoscopy because that would be relevant in a GI clinic, but you get my point. Like anywhere that you go for internal medicine, that you would go for your primary care, you can't do that as an acute care. You haven't been taught that. You shouldn't do that. And if we're going to say as acute cares, you shouldn't work in the hospital or particularly in the ICU with your FNP, then we have to hold ourselves to that standard from the inverse side of things. We should not be managing people for the long haul. We're doing acute problems that are resolved quickly, either in death or an improvement and moving on. That's acute care. It's a short-term problem. Yes, you can absolutely be certified in both. Nor gynecology. Honestly, don't know what I would do if you weren't here every single week. I really don't. Yes, you absolutely can. You just have to do the programs. So most schools will offer what's called a postmaster's certification. So if you already have your master's or your doctorate in acute care, you can then in 2 to 3 semesters get your FNP. You're just adding on that family piece of things. You're adding on the peds, the babies, the mommies. I think I am most jealous of people who are dual certified in FNP and acute care because you could do anything you want to do, really, aside from like super special stuff like what Mr. Midwife does. You probably can't do. But I think you would know that going into it if you want to do that kind of thing. So yeah, absolutely dual certify away. It's just going to cost you more time and money. And honestly, the biggest hassle, I believe, for the FNP thing are the clinicals. You have to get clinicals in each of those specialties. And it is really hard, from what I hear, my friends who are doing it, to get into those niched fields where they're inundated with students like OB, like peds. It is really, really hard to get those rotations. And I hear people like sharing horror stories about not getting their hours in and having to delay graduation because they couldn't get their rotations in. So if you're doing FNP, probably even more so than acute care, I definitely recommend you go to a school that you are fairly confident will help you find clinicals, which is a whole nother tangent I could go down. But yes. Okay, so that wraps up that post. We're an hour and 2 minutes. Are y'all impressed with me? I'm getting better and better at not going off on major tangents, so y'all don't have to sit here and listen to this for hours on end. Did I answer everybody's questions? I believe I did. Yep. So next week, what are we talking about? Next week, procedures. The blog post I just wrote was on procedures. So procedures that an acute care NP would do in an ICU setting. Some of it is more than just ICU, but that's what I know, right? So ICU setting procedures you can do, and there are a lot more than you probably think, and some tips about, like generic tips about these procedures. So check that out if you're interested in that. And if you come up with any other things you want to learn about, just let me know. Although right now I probably got more ideas I can handle right now. But this is a little bit of the plight of the ADD person. Way more ideas than you have time to actually do. But lately I got a couple like really good requests from people on YouTube that I'm going to start working on some content for. So with that said, I hope that y'all have a great week. I hope this was helpful to you in your journey, wherever you're at. I love having people across the spectrum in their process of considering going back, in the throes of it, and already out. I really appreciate all your input and for coming and joining me every week. It really means a lot to me. So y'all have a good night. I hope your night at work is as fun as mine should be. Or maybe you're not working. See y'all next week. Bye, everybody. You're welcome. Thanks, Alex.